right, well, why don't we get started? I'm Neil Newberger from Health Tech Strategies and McLean, and welcome to all of you. Great crowd today. We had over 230 registrants, and I see a lot of familiar faces. I want to thank Senator Whitehouse's office, Sheldon Whitehouse from Rhode Island. It's been a busy few weeks up here, as you know, and they are not in session today, so we won't have a member as we often or usually do, one or two members to kind of kick it off. That said, we've got a great program, and Senator Whitehouse's office, Alexandra Fox and Jen DeAngelis, who made a lot of great arrangements. One thing that got lost in the translation, probably I'm sure on our side, is that the projector didn't make it. So we're going to spare you PowerPoints on the wall. However, and you should also, we will post the video, which is being taken to various member group websites and to YouTube, and that will include all of the slides. So don't worry about that, and folks will just, and they're comfortable just speaking from their slides. As I said, many of you have been with us before, and as you know, I've been part of facilitating and coordinating since 1993 well over 200 lunch briefing sessions and technology demonstrations all up on the Hill around health IT and telehealth and remote patient monitoring kinds of activities. We've covered just about every topic in that space you can imagine several times over. And Joel White from HIT Now Coalition has reminded me that I'm one of the biggest purchasers of box lunches on the Hill. We usually average about 100 folks at these things, so times 200 is 20,000 lunches that we've provided or served. It's like McDonald's, you know, and it tastes like, no. So we're so pleased today that we've got the collaboration, coordination of the major HIT, telehealth, remote monitoring groups here with us, and those are American Telemedicine Association and the Connected Health Initiative from within the ACT Association, and HIMSS, and Health IT Now, and the eHealth Initiative. And in just a minute, we're going to hear from all of them for 2 or 3 minutes before we get to the main speakers. I'm not telling you anything that you haven't never heard before, like only every day if you're in this field, but now opioid overdoses are causing over 70,000 deaths per year, which is more than died in Vietnam or yearly in car crashes, even at the height of car crashes in this country, and it's never been over 50,000, I don't think, in the last 20 years. The good news is that government at a federal, state, and local level, and a lot of organizations and companies are pulling together now to try to do something robust about all of this. And I've said for a long time that when it comes to health IT and technology and telemedicine, that it's one of the few issues up on the Hill where there's near unanimity and a bipartisan approach to all of it. And it's been that way, and I think our colleagues from the trade groups would agree. So we don't often face the kind of rankling and everything that's going on up here, and that's the good news. The other substantive issue lately, where that is also true, as evidenced by the bills that have just passed in both the House and the Senate and in conference committee, is the opioid crisis thing. So it's good to be working in that environment and not have to, you know, sort of wend your way through the politics of a situation, because there really are no politics at a major level for all of that. So with that, let me just make a couple quick comments from my slides, and then we'll turn it over to these groups. We're going to hear from these organizations, as mentioned, and from some really innovative companies about what's going on around various technologies that are being pressed into service and are on the drawing board and being planned in terms of things like blockchain and personal status monitoring and remote patient monitoring services and electronic medical records and PDMP, or prescription drug monitoring programs, data analytics, telehealth, telemedicine, and I even saw a story not too long ago about how virtual reality is being pressed into service for mental health as a way to help address the whole situation. We're going to, so just for a second, there have been a few major bills and agency activities, which I have on a slide, and as I said, I'll get these to you. The main thing that happened funding-wise was the Omnibus Appropriations Bill for 2018, which included about $3 billion increase to make a total of about $7.4 billion across 32 programs within the government around the issue of opioid, and that's scores of agencies. $1 billion in grants to states, including states that are leveraging health information exchanges like Florida and Connecticut. On the House side, on the authorization side, a House bipartisan bill, H.R. 6, was passed in June, 396 to 14. The Support Act, which packaged up 57 separate bills and an awful lot of provisions. It's something like 680 pages just by itself. The Senate passed its bipartisan bill, S. 2680, 99 to 1, the Opioid Crisis Response Act, led by Senator Chairman Alexander, in September. And then just last week, the conferees met on the legislation and hashed through both bills, so now it's back before both the House and the Senate for final approval. CMS prospective payment rule has a new e-prescribing measures in it, EMR reporting periods, the use of APIs to increase information flow. There's a major Surgeon General's report that was out in September that I encourage you to get a hold of, and some pending legislation, including by Doris Matsui, the Access to Telehealth Services for Opioid Act, H.R. 5603. I think Joel or one of our speakers is going to talk a little bit about how telehealth has been incorporated into the bills that just passed. And then finally, just to mention it, the ALERT Act, H.R. 6688 by Representative MacArthur, which is called the Prescription Safety Alert System, and I think Joel may mention that also. We'll talk about some policy takeaways at the end of this. We want to leave time for questions and answers. If you want to tweet this out, we're using @Opioid Tech Brief, okay? Opioid Tech Brief, all one. Hashtag. So we're twittering that out, or whatever you do when you... My daughter, Madeline Newberger, is here to help, and she told me, Dad, don't use the wrong terminology. So anyway, with that, why don't we just go right down the line. We have Jennifer Brodeneck, who's the CEO of the eHealth initiative, and she's going to share a few words with us, and then we'll introduce Joel. Jennifer, thanks so much.
Good morning, good afternoon. I'm Jen Kovich-Bordenick, the CEO of the eHealth Initiative, and really delighted to be here today. What's really exciting to me is that we have all of these different groups here together, and I think that tells you a lot about the opioid crisis. Opioid touches us all. I personally faced the challenge of addiction when I dug myself out of a hole of pain following spinal surgery about 2 years ago. My 14-year-old's friend's father was just found dead of an overdose a couple of months ago. I think we all have examples of this. But we need to stop saying how opioid abuse touches us all. I really feel like touches us all is kind of the new thoughts and prayers phraseology of inaction. Like Neil, I think we need to start talking about how we are going to take action and band together. The recent legislation and the money is a good sign. Definitely want to get that point in. But Jesse's Law, e-prescribing of controlled substances, some of these intensive addiction programs, they work, and we know they make a difference. We know a lot of these innovative technologies work, but we need policy now to support the free flow of information so people can actually use the technology, and we don't have that yet. In fact, to that end, there have been a few disappointments recently in terms of the legislation, but that's not going to stop us. In 2004, eHealth Initiative led the charge on e-prescribing. Remember back when, before they didn't have that? The fact that I can see the results of our work during my lifetime, 14 years later now, has really brought me a sense of satisfaction. It's great to see e-prescribing in all of the doctor's offices. But little did I know I would be back here again, trying to address many of the same problems. Our organization is going to continue to educate both private and public sector leaders to make this happen. eHealth Initiative has convened dozens of executives in 3 roundtables. We produced 2, 3 briefs. A couple of them are available here today and also online. We had a town hall about 2 weeks ago, and we're going to continue to do this and continue to push forward. I want to be able to make our children proud that we were those that took action and didn't just talk about it. And I hope 14 years from now that I'm standing up here addressing a different issue. And with that, I will hand it off to my partner, I believe Joel White from Health IT Now, who's going to talk. Right?
Yeah, great. Thank you so
Thank
much,
you.
Jen. Thanks, appreciate it. Thanks to eHealth. And let me also add, where did Claudia go? Claudia Ellison, who helped also set this all up on behalf of eHealth. The groups all did a great job just getting this turnout and to get the word out to the Hill, to the agencies, and Emma Valinsky from eHealth also, who's at the front desk. Joel White is one of the longtime former Ways and Means staffers, and you don't know what I was going to say, and leaders in this whole issue. They've been advocating around these and many more issues, as have all of these groups, for a lot of years, and he has a lot of on the Hill and legislative experience. Joel, introduce yourself briefly and coming up and say what's going on at Health IT. Thanks.
Thanks, guys. You can hold your applause. Thank you, Neil. I'm glad you're still feeding the world. But really want to appreciate your great service in helping to get some educational resources out to folks and talk a little bit about these pressing issues. When Health IT Now is a collaborative of about 75 different organizations. Our primary group of stakeholders are patients and consumers. So we really look at this from the end user standpoint. We want the technology and the data to work for us so that it can help us solve real problems and make healthcare better. And so when we started looking at the opioid issue a couple of years ago, we saw every self-respecting group in Washington, D.C. had some kind of an opioid angle, and we said, do we want to get involved in this? And when we dug a little bit deeper, we realized a lot of the challenges in the opioid world are really about information and data and applied technology at the point of care, and how can we use that to help clinicians make smart decisions about patients. And so our group got together and said, yeah, there's actually a few things here that we can do, because we do all have stories. And we thought it was important. And so we started getting the bills drafted and doing all that stuff. The opioids package that hopefully will pass the Senate this week has 4 of the provisions we worked on, but a bunch of others. There's about 10 technology-related provisions in the legislation in total. On the telehealth side, it really is about creating new reimbursement structures and pathways for patients to access care remotely, and that's in Medicaid and Medicare. That's really important for people who have substance use disorder, and who don't want to go to the physician office because they could be identified. Think about small town. I've got the red pickup truck with the, the bumper sticker that says something on it, right? And someone can say, well, he seems to be at the provider office every Tuesday. I wonder what's going on there. And it's the mental health provider. So some people are much more comfortable with telehealth. It's also easier to access. Some people are more sharing in that non-identifiable type situations. So that's important, an important step forward in both Medicaid and Medicare. In addition, electronic prescribing. We're seeing this increasingly at the state level for controlled substances. New York was one of the trailblazers here, requiring electronic prescribing for the controlled substances, now going to be required in Medicare. A huge step forward where we see better e-prescribing. We see higher rates of adherence, but also higher rates of compliance with medical guidelines, and also creates audit trails for folks to be able to be held accountable. So that's important. And then the last thing I'll mention is electronic prior authorization. What we see increasingly is doctors spending a lot of time answering questions on the plan side, necessary questions, but that's holding patients up from receiving their medicine at the pharmacy counter. And that's really important for folks who are going through challenges in this space. So there was a lot done. There's other issues in the bill, behavioral health IT bill, for example, to get some additional resources out to providers who were left out of the meaningful use list, which Tom might speak to. But where do we need to go, right? Because it seems to me like this is a lot of discrete one-off solutions for one-off problems, but there's a bigger picture going on here, right? And the bigger picture here is that we've got a tragedy that's happening. But it doesn't seem like Congress is responding with a comprehensive solution. There's been some solutions put on the table, but it feels like that still needs to come together. And I think it will. I think we're going to have another bill next year. One of the things that we want in that bill is having actionable, real-time, in workflow, and interoperable information at the point of care. So if you're a prescriber or you're a pharmacist, you've actually got real-time information on that patient, which is not something that we're getting through the state-level PDMPs. And so those are very old systems that need to be upgraded and updated with the latest technology. It should be cloud-based, it should be real-time, it should be interoperable, and it should be in workflow. And I can say that over and over again. But that's kind of a as-yet to be done kind of item. As Neil mentioned, there's a MacArthur-Custer bill in the House. There's a Klobuchar bill over here on the Senate side. Those would all start getting us into the modern age where we've got that real-time data and information in front of the prescriber so that they can make good decisions about whether a patient needs an opioid or maybe they need other types of treatment. So really happy to be here today. Really looking forward to hearing the panelists. Thanks.
Thanks, Joel. Yeah, thanks, Joel. So it does all gets down to coordination, collaboration, and it'll be interesting to see where the department comes down on all of this. We did want to have, and he was unable to make it, Admiral Greer, who's the Assistant Secretary for Health in charge of all these issues. He does go out and speak a lot, but could not make it this morning. I apologize. That said, I introduced Tom Leary, and say something about yourselves a little also in your backgrounds. I've known Tom forever, since he and I both worked on the House side, and you worked for Congressman Les Aspin, who then became Secretary of Defense, and now he's the head of GR at HIMSS, and he and I have worked together for a long time. Tom, tell us what HIMSS and your groups are doing. Thanks.
Thanks, Neil. And what Neil failed to say is that he is also the Executive Director Emeritus of the Institute for eHealth Policy from HIMSS. So we've learned so much along the way from Neil, not the least of which is good food at Sweetwater on a Friday afternoon. So, but I want to, on behalf of HIMSS and the Healthcare Information and Management Systems Society and Personal Connected Health Alliance and all of our partners within HIMSS, I want to thank everyone for coming today, and thank you to Neil for the invitation to participate. As an organization, we've really had the challenge as far back as 2004 when, as Jen mentions, and it's interesting that our host for today, Senator Whitehouse, was big on pushing e-prescribing, and he and along with HIMSS and eHI and others worked together with SureScripts, and we had an event at HIMSS, I think 2005, suggesting that e-prescribing could actually, be something that we all would do, and that we would that states would get an award. And the first state actually that got an award was New York State. So here we are 14 years later, and Senator Whitehouse is still very much engaged in this conversation. And the sad thing is that e-prescribing of controlled substances is still a challenge. Most states have it. I think it's most, if not all, states have the opportunity, but only 26% of providers have access and actually utilize the process. So that's one of the issues that HIMSS is really pushing for in this this year and into 2019 is to begin to educate providers more on the use of it, to be able to tie into, as we talk about interoperability with PDMPs and engaging more with just the overall issue of making sure that providers have access to that secure data. We were blessed just in the last couple of days of being up in Toronto with the Center for Addictive and Mental Health, which is going to be a Davies Award winner in a few days. But they have figured out how to within the province of Ontario how to engage in electronic prescribing, just this side of actual electronic prescribing, because in Canada, they're fighting a lot of the same issues that we were fighting in the United States 14, 15 years ago, being able to actually e-prescribe controlled substances. So it's important for organizations like all of us to work together on advancing provider decision-making as we tackle the opioid issue, but also remember that we're a beacon of hope or a beacon of light for other countries that are struggling with similar issues but don't have the advancements in information technology that the United States has come to enjoy over the last decade. So with that, just a reminder that next week is National Health IT Week. We actually, our message, our virtual march on the state is about e-prescribing of and other aspects of the opioid crisis. So encourage everyone next week to get involved. Keep the momentum from this week going into next week with the virtual march on the states. Thanks, Neil.
Good. Thank you. Thanks so much. And I have in mind, and I think the groups do too, a couple of you mentioned it, keeping in touch on these, ongoing collaboration between these organizations, just, especially given how critical this is. Not sure we've done that around particular issues in the past so much, but this one definitely lends itself to that. Thanks, Tom. So next we have, on behalf of Morgan Reed, who's the head of the ACT Association, the App Association, and Graham will tell you what that is. Graham Default from the Connected Health Initiative, which I think it started out as a multi-stakeholder group around telehealth that we were all part of for a bunch of years. So Graham Default, come on up and tell us what's going on at CHI.
Well, thank you, Neil. We're privileged to be here, and the Connected Health Initiative, as Neil mentioned, was started out as a multi-stakeholder group or a consensus organization. Most, relevant stakeholders are physician groups, patient groups, in addition to the tech companies that support us and who are part of our membership. And we speak with a unified voice on issues that are important to tech companies, but also to patient groups, physicians, and then the research universities that are part of our coalition, which include UVA Health System, University of Mississippi Medical Center, UC Davis, and a couple others. And so when we talk about the opioid crisis, as Joel and Tom mentioned, it's part of a broader problem that we face. And we testified last week in front of the HELP subcommittee on rural health care. And I think it's very relevant here because, especially in rural America, you see opioid use disorder is a major problem, and being able to connect with physicians is a major problem. There are two main issues. There's telehealth, Medicare telehealth services, and then there's the ability to remotely monitor patients and for patients to remotely access their physicians and their care teams. I'd say those are two separate issues because telehealth is, the live voice and video component, and then you have remote monitoring capabilities and the ability to contact doctors and care teams with store and forward technologies. And so there are some really great advances that have been made. CPT code 99091 was adopted recently by CMS, and that is something that can reimburse for remote patient monitoring services using PGHD, the patient-generated health data. The Center for Medicare and Medicaid Services deserves credit for adopting that. But as we move to value-based care, we have to keep the pedal to the metal, and we have to make sure that, as fee-for-service continues to start to look at remote patient monitoring and using data and enabling care teams to use data and be reimbursed for those activities, we have to make sure that models like alternative payment models and the MIPS models are not disincentivizing providers from using tech-driven tools, which we know are working. University of Mississippi Medical Center uses remote patient monitoring for diabetes monitoring. It is extremely effective for mental health services as well. We have a member company called Promina VR that uses virtual reality. They were established in Michigan State and are looking to expand their model beyond that. And they're seeing excellent results. And they are really enabling physicians to reach patients where they are without having to pull the patients in and sit in the waiting room for longer than they should have to. So I think what these tech-driven tools are supposed to do is ensure that physicians are able to access patients and patients are able to access physicians, as opposed to making technology happen to doctors, making technology happen to providers. It's really about making it work for the system and driving down wait times as we kind of face down a physician shortage that could worsen over the next several years. And I think by 2025, we're supposed to have a shortage of 90,000 physicians, and population 65 and older is supposed to get to about 70 million Americans by 2030. These are perhaps scary figures, but I think if you enable care teams to reach their patients where they are at home instead of restricting telehealth to originating site, qualified originating site, and physician shortage area, and all these restrictions, I think then you are going to be in a situation where you're freeing up care teams to reach patients without putting a bunch of red tape in the way. And so I think that's kind of our overarching purpose. We are looking at a broader way of doing this. The narrow wins that we've gotten are excellent, and we're continuing to support those, like we saw with H.R. 6 and with the FAST Act and ESRD improvements. But we hope folks in the room will join us in advocating for kind of a more broader solution. So with that, thank you. Look forward to a great discussion. Thank you, Neil.
Thank you. Thanks, Graham. Really good. Yeah, and not only are we down 90,000 physicians, we're down a couple 100,000 nurses, nurse practitioners, allied health professionals of all kinds in urban and in especially rural areas. And the really scary thing I learned recently in concert with a project I'm working on out in Montana having to do with a simulation training center for rural areas is that a lot of that shortage, some of that shortage, and increasingly so, is opioid-addicted healthcare practitioners who have their access to the cookie jar. Yeah, I mean, seriously. This is something that's just now starting to, I think, come out more and more, and something that we're going to have to deal with increasingly. So the allied health professionals are aging out, they're burning out, and for all those reasons, it's affecting the health system. So last and not least, from the groups, and Ann Mund Johnson, the new head of American Telemedicine Association, which I've been a part of since the get-go for 25 plus years, was unable to make it today, but we're fortunate to have Tanya Malik, who's a PhD psychology type, I think, right?
No.
Oh, no, you're a JD.
I'm a lawyer.
You're a lawyer. And head of the mental health special interest group. Mental health's been one of the most robust uses and applications of telehealth that we know of, and for reasons we would have never thought of. And I think Dr. Darkins and others would appreciate that. But come on up and tell us about ATA and what you guys have been up to. I know you had a meeting recently.
Thank you. First of all, I am Tanya Malik. I'm chair of the Telemental Health SIG for the American Telemedicine Association. Thank you for all the work that you have done. Grant touched on it, and Neil just touched on it. There is a shortage of mental health professionals, specifically psychiatrists. They are aging out at the highest rate, and they are the lowest rate of residents coming. So that shortage, along with other mental health professional shortage, coupled with the opioid crisis in the rural areas, really has made this crisis even worse, and telehealth to us is the answer. When you think about all of the things that people have set up here, telehealth at its basis is being able to connect and allow care by any patient, anywhere, anytime. And the ATA supports any legislation that makes that happen. Specifically, where we're focused on this is the Ryan-Haight Act passed in 2008, and it required that you had to have an in-person examination before you could prescribe a controlled substances. During that time, I started a company that did online primary care. We didn't do any controlled substances, and we saw why you needed the Ryan-Haight Act. A lot of the people I knew were driving Lamborghinis and I think I was driving a Yugo or something at the time. But it needed to be done. It was a pill mill, and the legislation was really what was needed. The unintended consequences have been that legitimate providers haven't been able to prescribe in child and adolescent situations and for this crisis in particular. So in this legislation, in the Ryan-Haight Act, there is a exemption for telemedicine, but you have to have a special registration, and the special registration provisions really haven't been promulgated by the DEA, and this legislation gives the DEA the green light to move forward on that, and we're looking really forward to that. The ATA has been working closely with the DEA over the last several years to try and get that to move, so we're very excited about that. The other pending legislation that Mitsui has been putting forth that eliminates the geographic and making it more site neutral and provider neutral. We're very much in support of that. Any out-of-the-box thinking that we can do to deliver the care. When you think about telehealth, and we've been doing this for a really long time in the mental health space, as you said, Neil, we know that we have good outcomes. We know how to do it. When you think about how long we've been doing it, you could think back to even the Catholics, right? You sit in a booth, and we've been doing it a long time. We know how. Where we support it is any removal of any restrictions in 1834M, which would make it just more ubiquitous, and really to fight the mental health crisis that Americans face, and particularly more than anywhere else, is we've got to make mental health treatment like water, like air, that anyone can pick up the phone and just be able to access a mental health provider, and we triage you to the right level. And to make that happen, we would also support any move to increase broadband access. So that's where we are, and thank you for your time.
Thank you. Thank you, Tanya. So why don't we do this? Let's take just a few minutes and ask questions generally for these 5 folks from the organizations and trade groups, and then we'll move on to our 4 company speakers just after that. And so consider this a little break. And if nobody has any, I will call on people, and I know who you are. Cheryl, Austin, and then Mark Wine. Go ahead.
Medicaid, actually, if you go to the CMS Medicaid website, is very positive about telehealth, and the state laws generally are quite positive. So I think we have to be really careful when we lump telehealth together into one area and really begin to distinguish and learn from some of the real innovative things going on the Medicaid side.
Anybody want to comment on that, or? Yes, no? Mark Wine from the VA?
I'm Mark Wine from the VA Central Office. It's good to see lots of familiar faces. Telecommunications are rushing to implement and integrate 5G wireless capabilities across the economy, across the country. Health, medical devices are one of the areas of importance for capabilities advancing. You mentioned, Tanya, the importance of broadband. Can anybody just comment on the 5G expectations? I know in addition to antennas, routers, big data, big 5G, big data centers and smaller 5G centers that are alternatives, all will impact the capabilities for telehealth and connecting consumers with health issues like the one today. So can you just address your outlook? Telecommunications are also going to be rolling out different medical devices coming up in the next year once they get along the way with the technical capabilities.
Thanks, Mark.
I can just address it from the mental health side more. I think probably the best push that we've seen outside the government on the industry side is the Microsoft Airband initiative. If you know anything about that, that they are committed to crossing the digital, to eliminating the digital divide by 2020. And so they've started pilots in a bunch of different states, and they've been working closely with, and they've really been starting on veterans and VA and just making sure that things are connected on there. As far as, I think someone else could probably comment better on the legislation part.
Just to add to that, the Airband initiative is using unlicensed spectrum, so it's to sort of complement the 5G rollout. And what's really great about Airband is that it uses a lowish band spectrum, sort of around the TV bands, and it's white space technology that is able to go through buildings, over hills, and reach a much wider area with a single piece of infrastructure. And I think that's really important because that enables you to blast further out in rural areas and reach more people with lower cost. And so that's why I'm very excited about Airband as a complement to 5G. I think the main issue with 5G is it uses smaller infrastructure. You need more of it, and therefore the local and state laws that govern approval of those pieces of infrastructure are kind of designed for like 4G infrastructures, and so they are really designed to approve big towers as opposed to sort of suitcase-sized infrastructure. And so the important part is making sure that the approval processes are streamlined. The FCC just adopted an order to do that. We were supportive of that, and we're going to make sure that that happens.
And if you want belts and suspenders on the FCC order, you should pass the Thune bill that would, I think it's called the Small Cell Deployment Act, that would essentially create a process at the local level to speed a yes or no answer back to the infrastructure companies. And that's important because, we do need, it's a different type of infrastructure, and it's going to be in every single local area. We're already behind. So if we don't speed this process up, we're going to be even further behind. The technology will be available, we won't be able to use it to its optimal capacity.
Yeah, and then I'd only add, at some point, we need to reopen the Telecom Act and address what to do about the USAC, health pilot program, which has reached its limit year after year. Finally, $400 million per year in subsidies for what had started out as T1 and above connectivity 20 years ago when Snow and Rockefeller had done it. And now we need to take into consideration 5G, all these new technologies, and make some of that available for 5G and various kinds of technology. Anyway, the law needs to be reopened. And I think everybody's just waiting for that to happen broadly in the Commerce Committee, say in the Senate and things, right? Very good. Yeah, one last question, and then we'll move on to the next panel. Say your name.
Hi, I'm Daryl Roberts. I'm a evaluation scientist and a registered nurse with LMI. One of the things that has been coming up again and again is about what I believe it was you that spoke to, Joel, was about the PDMPs. The area that we live in here, I live in DC, I work in Virginia, my physician is in Maryland. And it's not very hard. Also, I'm a veteran, so I could have, I don't, but I could have access to VA. That would give me access to 4 different PDMPs, of which 2 are interoperable. One is not really part of the system per se, and the other one is kind of a bluebird. With that, each one of these systems takes only a minute or 2 for a physician or a nurse practitioner or other to access. When you have 12 minutes per patient, that adds up very quickly if you've got 4 of these to hit. What is being done at a national level by your organizations to not only encourage, but to jam down the throats of the organization whose building we're occupying right now to get these systems interoperable so that I, as a mental health professional, could perhaps go into one system and say, my patient has received X number of opioids in the last year, and I don't have to worry about reading 9 other systems?
Yeah, it's a great question. This is a huge challenge. We've had PDMPs around for a couple decades, and I think the technology is that old. The challenge is we see states mandating that they be checked for every script. We have now a federal Medicare payment rules that require physicians and folks in hospitals to check every time as part of the incentive payment structure. And we have H.R. 6 requiring Medicaid providers to do the same thing. So we're mandating that providers do these things. And what we see in the states with the mandates is very low uptake of actual checking. 20%, maybe as high as 40%. Why? Well, the tools don't work. And they don't work because they don't provide the information that's real time. That is, there's a data latency challenge. It's not in the workflow. I've got to log out of my system and go to a website and log in and enter a unique password and check the information, and maybe it's right, maybe it's wrong, log back out, get back into my other system, and continue on with my work. And as you indicated, not interoperable, even across 2 states, maybe 4 states. To be fair, progress is being made. But that's a broken old tool. And we're saying, you've got to use it, but it doesn't work for me. So what we're going to see is lower uptake, right? A lot more frustration, more burden on providers. What we have advocated for is a national, interoperable, real-time system that relies on a facilitator that would dip into the data transactions that occur every day at a pharmacy counter level to say, as you're sending a prescription from provider to pharmacist or pharmacist to payer, we're going to dip into that data flow, send that information to a national hub, like as envisioned in current federal law, that would then serve as a check to say, okay, is Tom an addict? Has Tom had another opioid prescription this month? Or was Tom just across the street at the CVS and now he's at the Walgreens trying to fill a script 15 minutes later with cash? Right, this national system based on the real-time transactions would pick up all those instances. We're not picking them up in the current PDMP system. So we've got a very old system relying on very old technology that's been funded by Congress for decades, and we need to get off of it and move to a system that actually works for providers and works in general.
Let me just comment on that. I really think workflow, and we hear this often from providers, is the biggest issue here. You know, like you said, the example you just gave, you know, it's too big a pain to go and check it. So even when the technology is there, I think in place, we haven't made it easy enough. You know, we can't make it an afterthought. It has to really be a part of the system. And until we figure that out, I think we're going to continue to have this challenge, which is unfortunate, but it's the place that we're at right now.
And I have to say there are 2 bills. MacArthur and Custer have a House bill, and Manchin, Klobuchar and Manchin have a bill over here on the Senate side that would create that data hub that I talked about. So we're encouraging people to look at that, sign on to it. We're also encouraging a GAO review of PDMPs to figure out how much money have we put in there and how effective have they been at reducing challenges. Because at the end of the day, it's all about right information in front of a provider to make a good decision.
Great. Thanks again to these groups, and get with them afterwards. Let's make sure we'll get you their emails and their contact information. Join them, participate, get on their committees, go to their annual meetings, go to the meeting next week for HIMSS, and all the rest. So thanks again. Thank you. So let's move on to the 4 companies, the first 2 of whom have been working together around a project that our first speaker is going to start to tell you about, and that is Wendy Boehner, who's the solutions architect for Intel Health and Life Sciences, came out to be with us today from Chicago, and you have her little bio in front of you, so I won't talk about that any further. Maybe she can introduce herself a little further and the work they're doing with LifeWire and some other companies. Thanks so much, Wendy. Here's your.
Yep.
Thank you, Neil. And thank you for the opportunity to be here today and share ideas. I'm a health and life sciences solution architect. I have a background in security and interoperability. I spent 8 years at GE Healthcare. And I've been in technology, and I caught that healthcare bug back at GE, and I'm really excited to be working on this project. Like you say, it's about doing something and not just talking about it. I also want to thank Daryl, who's over, thanks Daryl, for starting that conversation. That's exactly what we're working on. So I'm going to give you an idea about what the project's about. So Intel with LifeWire and Click and other partners is executing this project to demonstrate how technology can be used to combat the opioid crisis. Now, we will be addressing a difficult problem. This is a crisis that's taking 150 lives a day. It's something, I mean, we had some testimonials already. It's something that's impacting my neighbors. It's impacting colleagues, families, people that I work with. And we want to, I don't want to say that it's affecting us all in some way, but we are going to take action. We're going to be using our strengths, applying our strengths to the challenge. So the technologies, the components that are going to be part of this project will include blockchain to show the data transparency, to do data sharing, and to provide an audit trail of the data and the movement of the drugs in the community. So what you can't see is that this project is what we describe as combating the opioid crisis with a continuous community tracking model. So blockchain, telehealth, here's like, what about telehealth? Telehealth services powered by LifeWire, and that's going to be engaging the patient to manage their drugs in their pain management in a responsible way. Click's visual analytics are going to be surfacing the insights from the data that we're gathering, and we're using that data to analyze and come up with these insights. So those are the three main components of the project. Health and Human Services, you may have seen what they have recommended. They've got a 5-point strategy for how to address the opioid crisis. This gives us a structure to follow and a strategy to follow. LifeWire services are monitoring the patient progress and their adherence to the drug protocol. The aim is to reduce new addictions, and this is directly one of their points. The better data will be brought to the crisis in terms of gathering the tracking of the drug data from the supply chain to the community to the disposal of that drug. And then the blockchain brings together all that data and then allows these healthcare providers, this is exactly what we were just talking about, Daryl. So the providers now and the pharmacists and we're bringing it into the community as well. So those community service organizations that need to know how to help their community, they have access to this. And it's a comprehensive look at up-to-the-minute data that helps them responding to issues on the individual level or at the community level in dealing with the opioid issues. The project aims to, I'm not claiming that it's going to be solving everything, but it aims to expand our wealth of knowledge around this, but we have a shared knowledge around what can be done to address the opioid crisis and how technology can help. Now, the use of blockchain in healthcare is very new. It's a technology that needs to be proven. We need to have more proof points. And blockchain has a central role in our project. It's going to be providing that B2B data interactions, and it's going to be providing data interoperability. The patient-generated data, drug provenance, drug location, this is the type of information that's going to be stored on the blockchain. Also, the blockchain will be auditing the data that's used and providing a provenance for the AI analysis that occurs. So you will have an understanding of how did we come up with this insight. The blockchain provides that for the Click dashboard. Patient data will be stored off-chain and accessed securely through secure credentials when needed. The data that is stored on the chain will be the minimal data required in order to monitor the medications in the community. And here's my plug. Intel servers are going to provide that infrastructure. You don't get to see all the great things it does, but I was only going to give it a little short plug. Yeah. So Click, one of our other partners who can't be here today, they have been actively addressing this crisis, and they have a number of use cases that we can build upon. They're working in the community. They're working with Jefferson Health to, in Philadelphia, ClickSense is being used there to inform the physicians of the patient history and building it into their workflow, which we know is important. We can see the patient history. You can see overall trends of the ordering. And these providers at Jefferson Health have among other, there's a number of things that it provided, but one of the key things that stood out to me was that they can see when a patient has ordered or fulfilled a drug, an opioid prescription more than twice during a 30-day period. So this is very helpful to them. Another use case they have is within the community, and they've been to Surrey, Ontario, and working with their emergency responders. They provide a dashboard that shows the opioid hotspots, the overdoses that are occurring in the community. This allows their emergency responders to be more prepared to respond. That's their job. And also to do it in a timely fashion. And one of the things that they're seeing is in the community as a whole, they're able to see when a bad batch of drugs hits the street, and they can provide a comprehensive response, reaching out to the community with alerts and things of that nature to reduce the number of deaths. So they're doing a great job. And now our telehealth component. Telehealth can be delivered with tools that patients and their providers have today. It can be something as simple as a phone call or an email message. Mainly, the telehealth tools are a means to enhance care, so that's what I try to keep in mind as the bottom line. So LifeWire takes advantage of existing infrastructure to enhance care, and Howard's going to be describing that and the unique value that LifeWire brings to this. We look forward to sharing the results of our efforts and demonstrating how technology can help with combating the opioid crisis. We are looking to deliver meaningful results that can change our communities for the better. Thank you.
Thank you. Thanks so much, Wendy, and to Intel for taking a leadership role on something as important as this, a company that size that's going to get down in the trenches and make this work. Did any of you happen to see 60 Minutes last night? Yeah. Okay. And what was it about? It was about especially a particular, and I won't mention the name, pharma company that many of us know who they are, and a group of physicians, a couple of whom are in prison, one of whom for the rest of his life, for prescribing tens of thousands of pills to a particular people in Florida and elsewhere. So can you imagine when a system like this, in a closed loop, a continuous tracking loop, becomes operational and you can track the otherwise diversion of these pharmaceuticals, the implications not only for the patients, but for law enforcement and the legal system too, something that kind of just occurred to me. I mean, it's going to be really important tools for society to get a handle on. So next, and Wendy mentioned Howard Rosen. I've known Howard, who's been with us on our programs many times over the years on behalf of HIMSS, on behalf of ATA, EHI. Everybody knows Howard, even though he comes down here from Canada only once in a while. We last year did a program together on comorbidity of PTSD and TBI, something that he has a lot of experience with the VA, with Mark and Dr. Darkins, who's in the audience, and others in the room from his organization and former feds and things. And he's been one of the leaders not only on those issues within some of the visions of the VA, but on this issue in bringing folks together, and he was really one of the impetuses in putting this whole thing together. So we really appreciate it and working with Howard on an ongoing basis. So Howard, come on up. I know a couple of your folks are also with us today, and you might mention them and tell us more about this project. Thank you.
Okay, well, thank you, Neil, and thank you, everybody, for coming today. And obviously have everybody who's on this panel. And thank you, Wendy, for doing a better description of describing what we do than I certainly will. So I probably sit down now, it'd be a lot easier. And where'd you put my, and then he blew.
Yeah, I know.
Yeah, I know. So
We talk about technology, all of us. We don't do technology.
well, the irony of Neil talked about, I've made a few presentations. My first presentation on the Hill was actually in this room about, I think it's 9 years ago, 10 years ago. And when did that presentation, his first presentation, I asked Neil, do you have audio visual, do you have video? He said, oh yeah, no, it's great, it works really well. My first presentation, hit the button, the whole system dies. A little bit of smoke coming up. And so I take some responsibility for the PowerPoints. Slides not working again today, just.
Jinxed.
So thanks for everyone's indulgence. My shadow puppets, exactly. Yeah, pictures are worth 1,000 words, so since we don't have the pictures, I apologize in advance for rambling on too much. When dealing with issues such as, and particularly with patients and healthcare, and particularly dealing with substance abuse, engagement is really paramount. And I know the E word is used a lot, and sort of people try to shy away from it, but the reality is, if you don't have all elements of the ecosystem, the patient, the providers, the pharmacists, clinicians, all engaged, many great solutions fall flat, have fallen flat, and will continue to fall flat. And so what we provide is that ability to connect all those pieces. Like if you look at the last mile between the patient and all the various solutions, as Wendy described in terms of monitoring. So we help monitor solutions and deliver them to the telehealth solution, which is event-based. And we find that as a way to enable them to get better sense of what they're doing and who they're doing with it. So the kind of work that we're doing is we work in both the public and private sector, as Neil mentioned. We're doing pre-op and post-op work. We do wellness work in the public sector, in the private sector. In the public sector and federal group, we're doing work in such as areas as post-traumatic stress, high-risk suicide. We do substance abuse. And in fact, in some cases, you have populations who encompass all three of these. Particularly as a group, we're working actually in the VA, which is a maternal care program that involves combat-trained female vets suffering from post-traumatic stress who are pregnant. There's a high incidence of substance use, and there's a 78% probability of a suicidal event. So with that, we've gained, in working with our clients and helping them provide their solutions. Again, it's our solution working with them to better enable our clients with what they're doing. We've gained a lot of insight in the whole area of opioid management, and we're always looking to expand the breadth of what we're doing and how we can help our clients further. And in fact, that regard, I'm very excited that today was the public announcement of Ike Harper, who's at the back of the room, who's a former colonel in the U.S. Army and the chief pharmacy consultant for a number of years for the U.S. Army, who's come on board as our pharmacy consultant to help us in medication management, particularly dealing with the areas of opioid management. So in terms of the technology and patient engagement, really the objective is what you need to do is where the technology is almost invisible for that conversation to happen. You want to take away the communication barriers to the extent that you can. And so what we're always striving to do, and with our clients, is to take the situation where you have it's as if the patient and the clinician or the provider are sitting in front of each other, but treated on an automated and remote basis. So take those relationships and expand it. And again, key to that is reducing the whole barriers to communication. So what we do is the patient could determine whatever device they want to communicate on. So they could be a mobile device, could be a computer, could be a laptop, could be a landline, and they choose how they want to communicate. So it could be text, email, interactive voice, chat, instant message, any number of apps. We actually now tie into over 400 wearables and medical devices, and without the need, no software whatsoever, no special equipment. It's whatever device they have, and it's instantaneous. That starts the process of the communication that our providers have with their patients. And also for this, it's crucial to break down as many barriers as possible. So it's not just engaging the patients, as I said, it's engaging the clinicians and the providers. So instead of telling them, oh, you got a whole bunch of new things you have to do, we literally work with them to say, however you're whatever you're doing now, whatever your workflows are, whatever your protocols are, that's what you can continue to do. We just automate the process and use the rules engines and the rules of our clients to essentially automate the process, but escalate the exceptions so they're notified when they want to be notified about what they want to be notified to allow them to manage the patients that they want to manage at that point in time. So again, it's taking all these experiences that we've taken and working with our clients to deal with particular areas. One, as I mentioned, is substance abuse and opioids. And it's a great slide if you can only see it. So imagine, if you will. They'll be getting, okay. So I'll send commentary with it, it'd be great. So again, an example is with one of our clients, we're dealing with substance abuse and opioid management, and their whole issue was relapse. In their particular case, they had an average of 30% relapse. They've reported to us when they've used LifeWire with their system, it reduced down to 13% in the relapse with that population, and continues to refine. And again, this is what we're enabling our clients to be able to do. It's not our protocol, it's really using their system, but managing in a way, using our platform to allow them to communicate to a broader population that they hadn't before, and allowing them to communicate how they want. Because again, it goes back to, don't tell them how to communicate. Don't let them tell you how they want to communicate. If they want to use a cell or a text or email, and it changes over time, depending who you're talking to. And if you're dealing with, again, our experience in post-traumatic stress and substance use, sometimes they change even devices. And so it's key to be able to have them comfortable communicating with you, and at the same time be able to follow them at the same time, all with permission. So they're the ones engaging the system. But the respect that they get through this process has been empowering from our experience that we've had. So in particular to the discussions that we're having, and as Wendy had said, we're building a collaboration of companies really to demonstrate how to use blockchain linked with patient engagement and population monitoring to explore how to connect all the sort of the dots of data and patient engagement with the goal of helping to reduce addictions. And so, ultimately, patients need help managing their discomfort. Post-surgical pain is a perfect example. And as an example of contributing to the opioid crisis. And providers do want to help, but it's how do you help and how can they help? And it's something they're all looking at. But reality is real-world logistics tend to get in the way. So by using technology to sort of continue the conversation, even on a virtual basis, with the patient, help manage their transition to over-the-counter or whatever the transition pieces are, is critical to helping to reduce the addiction. It's part of the process. We're not saying we're the solution, but it's working with the solutions and helping to pave that way. So again, for this, as Wendy had mentioned, for this collaboration, LifeWire is really involved in patient enrollment and records consent as the start of the process, because it's a very consent-oriented piece. And who are identified by the provider and, again, with permission from the patient themselves. And then it's entering into an interactive and proactive messaging and dialogue relationship with those particular patients, tying in the providers and the various elements in the system. So for greater examples, pieces of what we're looking at, again, this is a demonstration project. We're still putting some of the pieces together, but the idea is really to be a recorder of the patient's status and some of the provider's status, some of the pharmacist's status throughout the process, interacting with the blockchain. Again, PII staying offside, but collecting de-identified information. So the patient will, can self-report prescriptions, can self-report going onto the prescription system. How are they managing the pain? Are they engaging with our system or not? One of the things that we looked at, and this came out of the behavioral health side, and the biggest knock against communication is it's good as long as somebody's communicating. Well, one thing we did learn in behavioral health was the fact that non-response is a choice. In fact, a non-response is a response. So we actually enable our clients to measure non-responses and treat it that way. So if somebody doesn't respond to 2 messages, or if they haven't responded in an hour and a half, that can trigger a whole series of outreach, either to themselves or to the community of care in the ecosystem. So you get that 100%, you know what's happening to that patient or the information you're looking for at any point in time. 2 other things we're looking to measure is is there any unused medications? It's self-reporting and interventions in the needs of either, again, the provider or the patient. Are there leftover medications? Have they completed the course of medications? Again, it goes on and on. I don't want to overwhelm you with all these points, but the key thing is there's a wealth of information to gain to add to the insight. And I think it's really, we're at the tip of the iceberg to really get a sense of really what are helping to what drives some of these issues and what helps to help the patient and treat them as an individual as opposed to saying, here's the solution, and to be able to zero in more clearly on technologies such as the blockchain and some of the things that we're using and other partners to help individualize that issue. It's kind of precision medicine, but it's but on the side in terms of precision behavioral health, for lack of a better term, is really what we're aiming to do, and looking forward to working with this demonstration project as just the start of what works and what doesn't work, but what kind of insights can we get. So again, thank you all very much for your time today. I appreciate the opportunity.
Thanks, Howard. See, Canadians are really nice people, aren't they? They come down here. Howard's great. We've been friends and colleagues for a long time. Next, we have Paul Uhrig, who's the Chief Administrative Legal and Privacy Officer for SureScript since 2006. After he left private practice, he's involved in a lot of groups that are important to the whole field of HIT, Direct Trust, the Sequoia Project. He's been on the board of the eHealth initiative, and he's a good friend and close colleague of Leslie Kelly Hall, who's here in the front row, came out from Idaho to be with us, who's also an advisor to LifeWire. Leslie, in her own right, nationally is known as a leader in consumer health and the patient-generated medical record, and has really been a leading voice in a lot of these groups just around those issues and keeping a lot of other folks grounded in that whole notion, and is just a brilliant strategist when it comes to not only that issue, but a lot of standards and data issues and some related kinds of things. So I know I'm supposed to be introducing Paul, but he's like, what the heck? We look alike. So Paul, come on up. Thanks so much to SureScripts and for your support. We really appreciate it. This stuff's not possible without, some of the organizations like SureScripts who can help make this all happen, and they're such an integral piece of the whole puzzle that we definitely needed them up here. So he's going to talk about the tools that they use to track the whole thing, and PDMP maybe a little bit, and some other issues. Come on up, Paul. Thanks.
Thank you very much, Neil. So I am Paul Uhrig, the Chief Administrative Officer of SureScripts. Thank you for having me here today. Today I am going to talk in a little bit more detail on 2 things that we've already touched on. So e-prescribing of controlled substances, or EPCS for short, as well as medication history and how that can help in this fight against the opioid crisis. So just to give you a little bit of history about SureScripts, I think a number of organizations say they're the largest clinical network in the country. I'll pile on. We believe we are one of the largest clinical networks in the country. We did start in 2001 to digitize the prescribing process with help from EHI, HIMSS, and others. We are now at a point where about 80% of prescriptions are e-prescribed. I suspect all of you have experienced that, so I won't get into how that works. But today we are connected to virtually every electronic health record company in the country, virtually all pharmacies, and all PBMs. And so last year we managed about 13.7 clinical
13.7 billion clinical transactions, and we send about 4.8 million prescriptions each and every day. So what does the data show about the opioid crisis? We know that about 13% of all prescribed drugs are controlled substances. We know these drugs are very important for care, but are subject to abuse. And we know that paper as a system was thought to be less secure, right? Easy to forge. Data shows that 3 to 9% of diversion occurs just because of people altering the paper prescription. So that's why the DEA got involved. We started talking to the DEA really almost at the inception of SureScripts back in the early 2000s to encourage them to allow e-prescribing of controlled substances. As we know, they look at things through a law enforcement lens, and so they spent a lot of time looking at the issue because they wanted e-prescribing of controlled substances to be more secure than the paper process. So we know in 2010, right, they adopted their regulation. It's still an interim final rule at this point, allowing for e-prescribing of controlled substances. We know we then worked with the states for a number of years to bring them in line with federal law, and as of about 3 years ago, all states are now in line with the federal law. What did the IFR do? Right? It made it more secure. So it required things like two-factor authentication. It imposed security requirements on prescribers, on EHRs, on pharmacies to really make this a much more secure process. So, is everybody using this technology today? So sadly, the answer is no. So when we look at 2017 data, 73% of all drugs are prescribed electronically. But when you break the numbers down, the numbers for EPCS are not that encouraging. While 82% of non-controlled substances are prescribed electronically, only 19% of controlled substances are sent electronically. So a huge gap as you look at those numbers. In some states, the situation is even worse. So if you look at a state like Ohio, which like many other states has some significant issues with the opioid crisis, 84% of non-controlleds are prescribed electronically, while only 15% of controlled substances are. So why is this? Okay. Federal law is aligned with state law. We know that virtually all the pharmacies are in compliance with the law. So what the data shows is that it's really the prescribers who have been behind in adopting this technology. So nationally, about 73% of prescribers are using e-prescribing, but only 28.6% are enabled for e-prescribing of controlled substances. So again, a very significant gap there. So why is that? We continue to hear primarily two reasons. We hear this from prescribers, we've heard it from the AMA. One is cost, that sometimes providers are asked to pay more for this more secure technology. Secondly are some of the workflow issues around security in particular. ID proofing, right? Government wants to make sure that whoever's using the system is who they claim to be. Two-factor authentication in order to get onto the system. Right? I suspect most of us now use systems that require you not only to put in up your password, but you got to get a text with a number to also authenticate yourself to the system. So we hear that these are barriers. So what's happening to address this from a policy perspective? Basically mandates, both at a federal level and a state level. And while people can disagree, reasonable people can disagree about whether mandates are the way to go, there's no doubt that the data shows that mandates are having an impact. So in Ohio, where there's no mandate, only 18.7% of providers are EPCS enabled. In New York, which adopted the iStop legislation that was mentioned earlier, 76.1% of prescribers are now enabled and using e-prescribing of controlled substances. So you begin to see the effect. Now we have about 15 states that have followed New York's lead, that have laws on the books that mandate either e-prescribing of controlled substances or in some states, all prescriptions. New York is one of the states that did all prescriptions. Not all those laws have come into effect, but the others will shortly. And then we see other states that have proposed laws on the books to mandate it. And then, as was mentioned earlier, the opioid package that was just passed in the House and the Senate contains provision that would require under Medicare that prescribers prescribe controlled substances electronically by January 1 of 2021. So we're seeing these mandates come into play. So that's one of the technologies that we facilitate through the network. What else does the data show that affects the opioid crisis? Data shows that patients who see 4 or more prescribers and go to 4 or more pharmacies are 4 to 6 times more likely to die from an overdose. Okay? Why is that? Sort of the classic interoperability problem that many of us are trying to address. Providers do not have a full picture of the care that their patients are receiving. And that's where medication history comes into play. Now, Joel mentioned earlier the PDMPs and areas of improvement that maybe they could have, and Daryl highlighted that in his own experience. So, Daryl, I'm going to suggest that there actually is a system in place and that we've made a lot of progress to get to what you are looking for, and that is what we do through SureScripts in providing medication history. You know, with that medication history, providers have a much better picture of their patients and the drugs that they're on. So we deliver medication history to over 1 million prescribers in the United States. It is sourced from both pharmacies and PBMs. So we're getting data from the claims that are filed for the prescriptions, as well as the dispense history records from pharmacies. So that will also capture any cash pays that are being made. We'll deliver that regardless of how the prescription was sent. So it doesn't have to have been sent electronically in the first place. If it was sent by paper, if it was sent by fax, heaven forbid, if it was called in over the phone, all of that data would still show up. It's not limited to controlled substances. It's all prescriptions that were prescribed. We are a national network, so people in New York who go to Florida and back, we will capture that. Daryl, if you live in Virginia, I'm going to pick on you since you put yourself out there. If you live in Virginia, go to DC, that will be picked up as well. And because we're connected to every EHR, it is integrated into the workflow. So you don't have the issues that many of the PDMPs have, and you have to break your workflow. So last year, we provided 1.5 billion medication histories to providers in the United States. So how does it work? Daryl, I won't pick on you anymore, I'll pick on myself. I go to the physician who's using an EHR. The night before, the system launches a request that has certain demographic information about me. It hits our system. We have a master patient index of about 230 million covered lives. We can find where the records are based upon the pharmacies that I went to and who my plan is through. So if it's through CVS Caremark, we'll get the data from CVS. If I go to Walgreens, if I go to an independent pharmacy, we'll get that record. We aggregate it and we send it back to the EHR, integrated again. And all that happens in 1 to 2 seconds at most. So now when I show up, right, that information is there. Very important information to try to identify patients who are at risk of abuse. So not perfect, but I think we have made a lot of progress towards the vision that we have. So those are two of the things that we provide, hopefully giving you a better sense of that. And I look forward to answering any questions you might have. Thank you.
Yeah, really great. Thanks so much. And I'm assuming, Paul, that going back to the 60 Minutes piece last night, that Florida must be a lot like Ohio given state law differences that allow for medication mills and for, non-recorded prescribing and things. There's sometimes 30 in a block or something like that, right? That some states are much worse off than others in that regard.
Very true.
Okay, very good. Okay, and last but not least, and apologies always to the last person, is Dr. Ross Hoffman, who's Chief Medical Officer at Involve Pharmacy Solution, which is part of the Centene Corporation. We always need an insurer or a payer to go last to pay for it. No, just kidding. That's not how it's happening. He's here with Joe Musker from their Government Affairs Office. Joe, where are you? Right out here. We really appreciate Centene, and I think they're probably a lot more familiar in some ways with some of the population that may be at risk than some other insurers, maybe the Blues or Anthem or others could be, and maybe Ross wants to mention that also. Dr. Hoffman, coming up and tell us what you guys are up to.
Well, thank you, Neil, and thanks to everyone. Good afternoon. It's kind of funny that we're here at a tech conference and, the technology is doing what it does, which, just brings back my own sort of PTSD as a physician who's been a proselytizer for technology and trying to bring the unconverted along to the new way. And that, I think, is just sort of a karmic battle that I will carry with me probably into the next lifetime, because we have a lot of work to do. But seriously, the ease of use of technology is a non-trivial matter. And I think this has been a really rich discussion here to sort of emphasize that. I want to make one other sort of preliminary comment that I think is really important. It's been addressed here, but I want to really sort of punctuate it. And that is the workforce needs. We're not going to solve this problem and several other sort of chronic disease-related problems without filling the workforce. So we're hearing anecdotes of folks leaving the workforce, and so it looks like the delta is going in the wrong direction. I don't know that data. What I can tell you is that several of our plans around the country are working on this. There are some grants that are coming through, as have been alluded to, and so we have efforts underway to do some things such as creating certified recovery support workers in the state of New Hampshire, where our plan, working with community partners, has actually created training systems for folks to get trained and help members of their community. It's really inspiring because I think it's making some of these communities much more hopeful. And so I'll bring up that bright note. So a little bit of sort of background and introduction. So my name is Ross Hoffman. I'm the Chief Medical Officer at Involve Pharmacy Solutions, Centene Corporation. I'm a clinical and invasive cardiologist by background. And I've practiced in a variety of settings, from the urban academic centers of Boston to the Navajo Nation and to the high desert plateau of western Colorado, where I practiced for a good number of years. And so I've seen firsthand our nation's variability in clinical practice, access, and standards of care. Involve Pharmacy Solutions is an integrated PBM, a pharmacy benefit manager, and so we work with groups like SureScripts. We also have an integrated specialty pharmacy, so we sit on the delivery side of healthcare as well. All wholly owned by Centene Corporation, which is a Fortune 61 national payer. We do business in 31 states and have 41,000 employees roundabout, covering roundabout 13 million lives. And as Neil was mentioning, we do have a large volume of Medicaid business, which seems to be disproportionately affected by the opioid crisis, but not solely, for certain. So I want to comment on a few sort of opportunity points in the clinical delivery system. So the patient journey is difficult to navigate. Secondly, clinician access to actionable medical information is suboptimal. And I think solutions like SureScripts are helping to address that. And then thirdly, it shouldn't be surprising to people that all of this leads to a lack of both patient and physician engagement. And so, these three elements, the patient journey, engagement, and actionable information right at the point of need in a timely, seamless, in-workflow manner, as has been mentioned, really can move the needle. And so that's sort of how we focus when we think about technology and how to apply it to the opioid crisis as well as other chronic diseases. So before I get too technical, I want to talk about some results with some numbers. Over the past few years, Involved Pharmacy Solutions and Centene have intensified our efforts to manage the opioid use crisis in accordance with the CDC mandate of 2016. And this data is based upon 40 million pharmacy claims on an annualized basis. First, with regard to opioid prescribing, our total utilization has been reduced by over 37% since 2015. Opioid utilization of greater than 30 days, so longer-term use, has decreased by greater than 50%. And patient-centered care is improving as well. I think this was mentioned a little bit earlier, the use of multiple physicians or multiple pharmacies. Over the same time frame, we've seen a decrease of between 50 and 70%, respectively. With regard to MAT, that's a hot topic when it comes to reimbursement. We've seen improvements there as well as the use of naloxone, which is life-saving. For each of the past 2 years, we've seen a 300% increase in rescue drug fulfillment naloxone. And utilization of MAT has increased, depending upon how we measure it, between 200% and 300% for the past 2 years. So by any measure, there's unequivocal evidence that there's improvement in our utilization trends. Despite this fact, additional work remains. I'd like to now talk a little bit more about some tech-oriented issues that we utilize. From an analytics perspective, we currently utilize an internal developed predictive model. These are proprietary statistical analytical tools which identify high-risk and rising-risk patients at risk for the development of opioid dependency or addiction. We also have tools that we utilize with a partner to identify impactable, untreated anxiety and depression, which is a tremendously important issue, as these are often the underlying, more primary problems that lead to secondary substance use disorder. So we use this combination of analytical tools to then selectively outreach in a very targeted fashion to members to enroll them in case management or office-based programs to help them with their underlying behavioral issues and also to prevent conversion of short-term opioid use to long-term opioid use. I now want to shift a little bit and talk about technology platforms, and so I may use my hands a little bit because information is going to be moving and you can draw the picture in your mind. The data interoperability challenge is a big one. And I think we all know that the best clinical results require timely and frictionless access to precise patient-centered data. Having a single view of the patient facilitates more efficient and clinically accurate decision-making. Our work with Ravi Aika and John Scully's team at RX Advance is breaking new ground as we streamline the process, reduce administrative burden, and integrate pharmacy and medical claims, all in a unified cloud-based platform. So here's where this slide comes up. So imagine a use case where the patient is either having an encounter in the office at the point of care or in the pharmacy at the point of sale. What we've put together is a system which takes all of our membership's claims. So we are moving all of the entire Centene membership over to the RXA platform for pharmacy claims management. That's step one. Step two is we bring in what RxA calls their Nirvana platform, Nirvana 360. We take all of the medical claims and put that on the platform. Now we have the pharmacy claims and the medical claims together. We're missing clinical information, right? That's true Nirvana, but we'll get there. This information then, at a point of encounter, can be pinged going through an EDI, something like SureScripts or MDON, sort of depending upon the setting. Then it goes back into our system. We can also pull laboratory data. Then that information loops its way back to someone like myself or a pharmacist, who then is able to see alerts. So those alerts will come up, filtered. We have some other analytical tools that can actually interpret the data so that when it comes up for me, I'm not scrolling through spreadsheet screens of data that I need to check before I can make a decision. Rather, the system is smart enough to say, this patient has a cash fill on this date. Do you know that? That sort of thing. So the high resolution of that kind of data becomes immediately actionable, drives real engagement by the providers, drives engagement by families and patients as well. Now we're creating a system that works for us, as opposed to the feeling that so many of us have as providers and patients and families that the system doesn't really work for us. It works for other folks who seem to be sort of pulling the puppet strings. So that's kind of the grand picture of the platform that we are creating, and I'll look forward to being able to hopefully share more information on that sometime in the future. I want to talk a little bit about patient safety, drug security, and tracking opioid use. We have a couple of submissions to the FDA's Opioid Innovation Challenge. The submission final date, I think, was this weekend. Under this program, opioid prescription fulfillment is linked to deployment of a home-based Internet of Things remote monitor. This is a cloud-enabled medication dispenser. The dispenser has the following features. It's Wi-Fi or cellular enabled. Drugs are ID'd by an internal barcode reader. There are security and lockout features to reduce diversion. And there's a geolocation feature which tracks the device in case of theft. This smart dispenser is then linked up into the cloud in a care management platform with that information then looped back and pushed to caretaker, whether it be on the payer side from a case management perspective or over into medical offices where there may be teams working with patients. All of this results in early intervention based upon precise information. Using this, we're actually able to track increased frequency of use of opioids in patients. So we can identify those changes in their utilization patterns and then, again, in a precise manner, in a relevant manner, reach out to patients differently than much of what I've seen in disease management, which is outreaches sort of based upon the calendar, which also don't serve the patients well and don't drive too much engagement. Make two more mentions on engagement and education. We've introduced a proprietary psychographic profiling tool with a multi-channel communication platform. This enables us to personalize messages. The cadence and communication channel facilitates medication refills, symptom reporting on the parts of patients, and clinical escalations. This is being deployed. We've also identified a partner that creates quizzes, which have been developed at Harvard Medical School, using clinical content to help educate patients around their disease or their drugs, and in a gamified fashion. And we're linking that to incentives to drive uptake of that as well. From an AI perspective, we see AI as offering the opportunity to reach out to patients and provide more access. So we've seen a couple of tools out there that do a pretty nice job so far, in particular clinical scenarios, in providing triage. So sort of symptom tracker, stratification. I won't call it diagnosis because it's not diagnosis. It's kind of categorization and then options to then feed into the system. So imagine Alexa says, I think your headache is cluster. Would you like to talk to Dr. Hoffman now? And up pops the number of the office, that sort of thing. So we're looking at those kinds of tools. And then lastly, we have a digital medicines program underway with a partner that has a digital chip, which we link to pills. Our specialty pharmacy repackages the pills and then sends those pills home with the patient. The system elegantly identifies that the patient has taken their medication when it is ingested, and that's all communicated back through the cloud. My final comments, with the evolution of new sensors, the exponential era we're living in, and the additional tech-related, we have additional tech-related projects in the pipeline. The Internet of Things is coming to healthcare. This deepens the importance of creating a unified platform which integrates and harmonizes data in a clinically relevant and user-friendly manner. In summary, Involve Pharmacy Solutions and Centene Corporation are deeply committed to improving care quality and outcomes and access to our members while providing the most cost-effective care possible, one person at a time. I want to thank you all so much for your attention.
Thank you, Dr. Hoffman. I should think actuarially all of the companies are going to have to get on board and start doing exactly those same kinds of things in short order, just from that perspective. Joe White had to leave. Catherine Pugh's still here, and thanks so much for your help on this from the HIT Now Coalition. David Gray's here from HIMSS, though Tom Leary had to leave. So if you want to talk to any of these folks, get them afterwards, okay? Last but not least, let me have Madeline Newberger, no relation, is going to come up, and she's my daughter. We're going to do some Q&A. Again, please take this time, introduce yourself, wait for the mic. We are trying to capture all of this on video. Some questions? Thought of a good technical workaround. If we had a quick sketch artist and markers, we could just draw on the wall while people are doing their slides next time. But so, anybody? Yes, in the back, a couple folks.
Hi, Rick Rape with LexisNexis. I was wondering for some of the panelists if you could talk about how you combat some of the challenges of HIPAA as it pertains to aggregating patient data, history, the types of scripts, the milligram doses that they might be receiving. It's an area I know of constant discussion as I'm in communication with different payers and states on the ability to aggregate and use that information in more of a collaborative or contribution type setting.
Well, first off, we don't combat HIPAA, we comply with HIPAA, so I want to make that absolutely clear. We may be a little, I don't want to say unique, but may not have the challenges that you just referred to because, our model is for patient care, right? And so for our model, it is the delivery of information from pharmacies, from PBMs to providers for patient care. So, we have, as I said, we comply with HIPAA, comply with the state laws. Since it's for treatment, we haven't faced the issues that maybe others have faced in that regard for aggregation.
Yes, and my only comment is, where's my SVP of compliance? I need him here. So from a data aggregation perspective, I'm not aware of any challenges that we've faced. And we are an extremely diligent compliance-oriented organization. So what I can tell you is that the aggregated data that we use is all de-identified. And not being a compliance expert, my guess is that has fulfilled much of what we need. And what I can tell you is that on a regular basis, and we have numerous sort of informatics efforts underway, on a regular basis, we are more frequently looking at analysis of our data with our states, with state sponsors of MCOs, to identify additional treatment opportunities. And so I spend more of my time sort of designing and analyzing this data and then feeding it back to the plans so that they can meet with their states. And my experience is that there's a big appetite for it. There's interest in improving clinical outcomes, and HIPAA compliance has not come up in that regard as a limitation, provided that we are always using de-identified data.
Can I just comment? I think one of the issues has been being able to share information about people's addiction, and the Jesse's Law, which I think is, a lot of people are pinning their hopes on that at some point. So it's rather sharing the information once someone is addicted and being able to share that with potentially treating physicians and other folks.
Very good. Somebody else in the back, I think, Madeline? A couple more. Thanks.
Hi, I'm George Matthew. I'm the Chief Medical Officer for North America for DXC Technology. We used to be Hewlett-Packard and CSC. I had a question for Dr. Rosen, if that's okay. You had mentioned you were working on a pilot. Which populations are you working with in your pilot, if you don't mind me asking?
Thank you for the designation, but I'm not a doctor, and though my mom worked really hard to get me there, I had handwriting for it, so I was all set on that. In terms of population, obviously Wendy can speak to it as well. We're actually in discussions with, I can't say split, but a number of actually cities that we're talking to and with their providers to really make this, the intent is make it actually a community effort to involve the fire departments, police departments, EMTs as part of this whole process in terms of the outreach notifications and involvement as well as a local provider. I
think that covers it.
And that covered it.
Yeah.
Thanks.
Very good. Go ahead.
Hi, I'm Darren Washington with the Cherokee Nation. I have a question. You had mentioned earlier that you were working on getting the data backwards to the EHR. One of the things we have trouble with, and this is the DHA and the VA, is when people getting the data from SureScripts all the way back up, the clinical data and the clinical note back up into the record. You said you were working on that. Is there any time frame you think that might happen, or anything you can talk about that out loud?
Sure. You mean beyond prescription history? Is that what you're referring to? Yes. So we also have what's called a record locator and exchange service that we've deployed that goes beyond prescription history. So we are able to identify where patients have had care and offer sort of 3 levels of service then, right? So the first level is just to inform the requesting provider where the patient has had care. So, the use case is, let's say I'm in New York, let's say I'm in an accident, I'm in the ER, they can query our network. As I mentioned, we have a master patient index of 230 million lives, and we can identify where I've had care. And so in the first instance, we'll send a report back saying, Paul's, I'm making this up, has a primary care in Old Town, a podiatrist here, a cardiologist there, determine what physician that maybe the requesting physician wants to interact with. If those 2 physicians have some pre-existing way of exchanging records, so for instance, let's say everybody's in Maryland and they're all a member of CRISP, that HIE, I'm going to go non-technical here. We send the coordinates so that they can then use that system to retrieve the records. Or in the third instance, we can actually pull the record and send it. So that capability's been deployed, it's being built out, but we need more adoption, and we're working on that just as we did for e-prescribing. It took us many years for e-prescribing. It takes time.
One more question. How far does that data go backwards in time? So, for example, when you say you can look at where the patient has received care, does it go back 20 years, 10 years, 5 years? What are we talking about?
No, don't quote me on this, but I think we're only about a year. I think it's only about a year, maybe a little bit more, but it's not 20 years at this point.
Very good. Anyone else?
Hi there. I'm Ben Dukach from Curator, a little healthcare startup, and a registered nurse prior to that. I heard a lot about in-workflow, and I totally believe in in-workflow. It doesn't work if you have to go do something else. But I also think that workflow has more than just a button in an EMR, right? If you don't want to do it in your 6-minute visit as a provider, you're not going to do it, even if it's only one button, even if it's an app. And I wonder if you're approaching that sort of more human side of workflow, like the physician has 7 minutes to do 20 minutes worth of things, or a nurse has 10 patients to take care of in a limited amount of time. How do you address that part? Because that's always the part that gets me.
it's nothing, it's all done in conjunction with the client. So if it's working with the provider, for example, a clinician, we work with them as to what their workflows are. So they're involved in the entire process. It's not, oh, you're a client now, 30 days later, here you go. It's all done in conjunction with them because of the human side. That was a great example in terms of we try to look at the human side of digitizing the conversation. So we work with them. We actually do force our clients to do focus groups. So it's not just, here's a solution, it's actually working with sample patients, so they actually see where it works. Invariably, what they think is brilliant doesn't work when you come to those kind of relationships, but that's part of the shakeout process. So by the time they go live with it, it actually is something that works and actually does integrate to the extent they wanted to integrate and deal with those issues.
So this is a tough issue to tackle. Right now, I think there are processes and people being thrown at the problem. We're looking at some technologies closely, the chatbot AI technology that I described earlier, where we see a use case around patient intake, whether it be intake in the emergency department or in the physician's waiting room. The technology is built on DeepMind analytics capabilities and is already able to digest that information in summary form and zip it over into the electronic health record so that the provider has a summary of the intake. The patient could do that all on the front end, creating time. We've not implemented it yet, but we're looking at it very closely.
Cool. Yeah,
Thank you. Bill Schulbe, Reach IPS. We've got an interoperable, advertisement, but just a quick one. We have an interoperable platform for healthcare. Interoperable at 3 different levels, the care plans, EMR, EHR, as well as devices. My question is devices are going to kind of track the same way that medicines have. They're going to get more expensive. Ingestibles, subcutaneous. What's being done from a reimbursement to look forward from a policy standpoint on the device side? Because the technology challenge is, quite frankly, we think we've got something that already addresses that. We think that we can manage that data and it's scalable. So at the end of the day, how do we go through and really manage the cost of connecting that patient back? And what's being done from a policy perspective? Be interested in hearing your response.
I don't have the answer.
Yeah, I think it's a reimbursement issue, like everything we're talking about here, telemedicine, which I think is kind of the first, I hate to say baby step, but it's a big deal. It's very difficult to get these reimbursement and payment models through that pay for these types of things. So there's no easy answer. I think that's why we're all kind of looking at each other. It's the $20,000 question.
Yeah, absolutely. You know, and we talked a little bit about collateral technology kinds of things that should and could happen at, say, the FCC. And just as on the tech side, and then on the health side, there are things like that have been wrestled with for years around the Affordable Care Act and everything else that simply have to be addressed that will have that effect of helping with this problem. I think it's a good point. Really, really great. Anybody else before we, one in the back and then over here, and then we'll wrap up. Thanks.
Hi, Kevin Borcher from the Nebraska PDMP and the Nebraska Health Information Initiative. For Paul, I wanted to corroborate your numbers of the 13% controlled substances. Nebraska is the only state that's collecting all prescriptions now through the PDMP. We're finding 10%, and Nebraska is a rural state, so that makes sense. Another thing about capturing all prescriptions, I know how important that is for medication history and MedRec. And oftentimes I spell MedRec W-R-E-C-K because it is such a challenge and we need some better systems to capture all prescriptions. A couple of barriers or gaps and opportunities that you had mentioned earlier. The cost to pharmacies to be able to send or receive prescriptions, e-prescriptions, or through PDMPs or PBMs is very important to just keep in mind. And also rural access, big thing for Nebraska, to have prescribers being able to e-prescribe. Nebraska was #1 in the country back in about 2014, 2015 on EPCS readiness, according to SureScripts. We've dropped to #6, and some of it's because of mandated e-prescribing, which is great, but some of it now with Nebraska being so rural, some of those providers don't have access to be able to send, let alone with 5G, but any type of communication. So that's an opportunity for improvement there. Thank you.
Hi, my name's Joanne. I'm with Senator Cortez Masto's staff. I appreciate the panel. I know this is very tech-oriented, but you all kind of touched on basically reducing the amount of opioids that are going to be prescribed by the physician. But I'm just curious, so what happens to the patient when that flags? So if the patient's flagged by already having prescriptions done, and say I'm the patient, I'm going to the second place, is that pharmacist now supposed to be the one that's providing an intervention or be able to put me in touch and contact with resources that are available? Is it that physician? What's going on the opioid epidemic portion of that, other than just reducing the amount of prescriptions that are being placed?
Great question.
Because I feel like that I'm missing that piece.
Yeah, that's great. Somebody who's going to, Wendy?
Sure.
Okay, so I think what would happen would be that the ideal is that the provider looks at the patient's history and they see, oh, he's already in the last 30 days gotten another one. There's an issue going on of some kind, and I need to investigate this. I mean, maybe he's having trouble managing their pain. We need to discuss it, and we need to be aware, not just doling out, the next prescription. It may be needed, but it may need some.
So we have some experience with this, certainly at the provider level, and numerous initiatives underway, working with AHIP and other national organizations, lobbying for PBM access to the PDMP. The goal being to take some of the workload off of the providers so that we could actually query the PDMPs when able, maybe with bulk analyses instead of one at a time, ideally in machine-readable format. This is all sort of, future contemplation. But currently, we do have some states where we have licensed pharmacists within our PBM, and according to the state regulations, it is acceptable for our pharmacist at the PBM to query the PDMP and then to send out notifications to the provider network. They then work with case management, either on our side or staff in their office to engage the patient, to have a sit down and discuss the observations, getting the patient some help.
Yeah, it comes down to the human dimension, which we often forget to talk about when we talk about technology in healthcare. The handoffs, the acceptance and that part of it. It's not that the technology isn't there. It's there still is that element, right?
Yeah, what are we going to do once it's there?
Yeah.
I'm a social worker by trade, so that just seems like that gap is very...
Yeah, absolutely, absolutely. Yeah, great question. So, anybody, Dr. Boyd from TJ, any last thoughts? You always have something.
It's quite an honor to be with everybody. I just wanted to say that December the 6th of this past year, there was a meeting at HHS just out on Independence Avenue, and it was on actionable data, on data analytics. And I just keep bringing up, Washington State has a PDMP, and one of the use cases for our health information exchange, what do we have it? What does it do? Well, everyone is different. If you've seen one, you've only seen one. And they have a state, in Pennsylvania, we have 4 to 5 regional HIEs, and we're working on a state HIE. So the workflows there are unique. But in Washington State, the PDMP data is at it's on the statewide, on a statewide level, their HIE. And it seems like all the providers have access to the statewide HIE. So what they do is PDMP data is in the statewide HIE, and we all have access to it. So, but then they took the next step, and as a physician, workflow is critically important. All of that PDMP data on the statewide HIE is integrated into your electronic record. So if you're on the inpatient side or the outpatient side, you have PDMP data while you're seeing the patient. You're not having to do it. There's no little extra thing you got to click. It's right. So integration, and everybody knows that with IHE, XDS.B, that's an integration profile that's been around only for about 12 or 13 or 14 years. It's not new. You could get it implemented in probably an hour or a very short time. And, you can have all that data just integrated right there. So there's ways to do it. Workflow is so important. And what I didn't say is usability. It's right there. I don't have to go behind 3 screens. So you can exactly see, you need to write for something. Well, you can see exactly where they've gotten, and it's all. So that's a lever for your statewide HIEs. And I really think that providers, other people such as payers, part of our Regional Health Information Exchange. We're a founding member. We've been a hospital. We also had 3 founding members were payers. Those are insurance companies. So it's, your membership of your HIE is becoming more heterogeneous and so on. And I really think an HIE, either on the regional level, on the statewide level, can be a huge lever as far as a communications tool.
Yeah.
So
really
speak
great.
to people, and you can do it. But anyway, so that's one thing. So it's really kind of cool to see how one part of the United States has been addressing it. Baltimore is doing some incredible things. You were just mentioning the police, the fire, all, the city social services and so on, communications. Those people, I know those people. I know exactly. I've known them for a year. I can predict. So they have a lot of social information, and I think providers and professionals need to integrate more into these city-led and city-supported social services. You're going to learn a lot of things, and it's really kind of cool. So there's a lot of really neat innovation going on. So as we get AI, machine learning, and so on, it's really cool stuff. So we're on the cutting edge of a lot of neat things.
That's a great summary right there, Tom. Appreciate it, Dr. Boyd. 5 key policy takeaways that I heard and that you heard parts of. 1, establish a prescription safety alert system for real-time information to clinicians. 2, modernize privacy laws, particularly 42 CFR Part 2, to improve care coordination and informed clinical decisions. 3, maintain patient-generated health data that began in the 2015 Certified HIT edition in the rules. 4, require use of e-prescribing for provider-dispensed drugs to address diversion, as we heard from SureScripts. And 5, continue patient-secure messaging requirements. You heard many more. We'd like to continue this dialogue and discussion. I want to thank all of our groups and our companies who came out today. My last request for you is please take each of you a couple of those lunches down to either the U.S. Capitol Police at the doors, which we try to do, or Union Station if you're walking back, and give them to any of a number of homeless people who are always out there. Or if you haven't had lunch yet, have lunch. Thanks again to all of you for your patience. We're a little past 2:30. We will put this all up on the web, including slides. Thanks again.